Hello, today is August 4th, 2016, and my name is Laren Dolans. I'm the Clinical Services Administrator for the Wind River Service Unit and the Billings Area National P&T Committee Representative for the Indian Health Service. I'm going to review with you today the most current pharmacotherapy recommendations for the treatment of benign prostatic hyperplasia. Before we start, I do not have any disclosures regarding the topic we are going to discuss today. Here are the objectives that we are going to be covering. The first objective is to describe the contemporary therapeutic management of benign prostatic hyperplasia, including the benefits and risks of therapies. Next, we will review and generalize pertinent literature reviews, evaluations, analysis, and findings. Finally, we will determine whether changes are warranted to the current national core formulary. Last meeting, when Ryan was calling out for volunteers to speak, none of the topics seemed that interesting. However, out of the topics being covered during these 2 days, benign prostatic hyperplasia seemed the most interesting. Why? Because now that I'm over the age of 40, I think it is human nature as clinicians to look at conditions we may be at most risk for. BPH develops as a strictly age-related phenomenon in nearly all men, starting at approximately 40 years of age. Histological studies from autopsies have determined the following age-associated prevalence. From the diagnosis standpoint, it is the fourth most common diagnosis in men after the age of 50, and in the community setting, the prevalence of diagnosis of BPH is approximately 13.5%. One study discovered that prostate growth is at 1.6 annually as measured by the transurethral ultrasonography. From a Native American standpoint, I was not able to find any information comparing rates to the general population. Even though the term BPH seems pretty straightforward, it should be noted that the prevalence of BPH can be somewhat ambiguous, as terminology and diagnosis codes can somewhat muddy the waters. This figure shows the complexity in the different terminology associated with the prostate and bladder and why exact prevalence rates can be hard to determine. For example, you can see some areas of overlapping that might allow for duplication in some reporting. BPH has components of benign prostatic enlargement, bladder outlet obstruction, and lower urinary tract symptoms, or LUTS. So here we have two charts depicting what is currently happening in the U.S. in the treatment of BPH. On the left, we have the estimated breakdown of patients with BPH pathology over the age of 30. Those with the international prostate score of greater than 7 is 21.3 million. Another 12.9 million men have sought a provider for BPH, and 12.2 million men are actively being managed for BPH or LUTS. Out of the 12.3 million receiving active treatment, 54.8% are using pharmacotherapy, 35% are watchful waiting, and 1.1% are being treated by surgery and procedures. The overall cost in the U.S. is estimated to be $4 billion each year, and as you can imagine, indirect costs are as much higher, and these patients also miss work as a result of their condition. In BPH, enlargement of the prostate gland occurs, and as the name implies, it is non-malignant. This is from the hyperplasia of both epithelial and stromal tissue and predominantly affects the transition zone of the prostate gland. The result is narrowing of the urethra and increased resistance to urine outflow. This, in turn, results in the common lower urinary tract symptoms, or LUTS, as I mentioned before, that usually causes the patient to seek treatment. Such symptoms are hesitancy, straining, weak stream, sensation of incomplete emptying, frequency urgency, and urge incontinence. Criteria for BPH is outlined in the green on the slide and are commonly used in some of the studies we will be reviewing. IPSS scores of greater than 7, prostate volume larger than 20 milliliters, and peak urinary flow, or Qmax, less than 10 milliliters per second. Additionally, The American Urological Association has a symptom score. PSA is nonspecific but a good predictor of prostate size and clinical progression. A PSA level of greater than 1.5 generally correlates with prostatic enlargement, that is, size greater than 30 mLs. The exact mechanism for the development of BPH is unknown. Metabolic, hormonal, and inflammatory mechanisms have been proposed. As for the metabolic mechanism, it is thought that atherosclerotic vascular damage contributes to tissue ischemia. Tissue ischemia in the pelvic region have been shown to cause cultural human prostatic stromal cells to produce increased levels of growth factor, which leads to prostatic epithelial hyperplasia. Hormonal activity of testosterone and dihydrotestosterone have not only played in the normal prostate health, but also in the development of BPH and prostate cancer. Both hormones have activity on cell receptors, but dihydrotestosterone has a stronger affinity. Testosterone is converted to dihydrotestosterone by the enzyme 5-alpha reductase. Even though both enzymes drive prostate growth, their levels are not elevated in BPH. It has been postulated that higher estrogen-androgen levels that accompany age may also contribute to BPH. Pro-inflammatory stimulators, also thought to drive prostate tissue growth, contribute to BPH. Understanding these proposed mechanisms gives us a better idea of what medications have been used and will be the best for treatment. So you can see with this slide a depiction of the prostate growing in size with age and the level of testosterone declining over that time. The primary risk factor for BPH is age regardless of race, ethnicity, or region. Another factor increasing the likeliness of it is family history of BPH or molecular abnormalities of the prostate. Dietary factors including isoflavonoids and lignans in vegetables, grains, and soy may have a negative impact on the development of BPH. Also, some studies have supported the relationship between BPH, metabolic syndrome, and diabetes, which may be caused from insulin resistance affecting sympathetic nerve tone. Finally, erectile dysfunction and LUTS suggest a common etiology for these conditions. Serum C-reactive protein levels have been associated with LUTS, and the action of phosphodiesterase 5 inhibitors on BPH is thought to be due in part to the anti-inflammatory action. Finally, there seems to be a genetic component of BPH. The primary goals are to reduce LUTS, improve prostate-related quality of health, and prevent or delay disease progression. So not only are we interested in one's personal life, but also should focus on lost time from work and overall treatment costs. Whereas other conditions we focus on treating aggressively at the beginning and throughout the lifespan of the patient, in BPH we can take a watchful waiting approach. In one study, approximately 85% of men with mild LUTS were stable on watchful waiting at 1 year. In another 5-year study, the results showed that 64% of patients were able to remain in watchful waiting status while the remaining required surgical intervention. With education and lifestyle modifications, you want to counsel the patient on weight loss, increase in physical activity, and reduction of caffeine and alcohol intake. Also, it is important that the patient knows their risks for acute urinary retention so that it can be prevented. Another thought is avoidance of unnecessary medications that can aggravate the condition, such as anticholinergics, diuretics, and calcium channel blockers. Medications are the cornerstone of therapy throughout the spectrum of the treatment of BPH. The medications that are approved by the FDA are alpha blockers, 5-alpha reductase inhibitors, and one of the phosphodiesterase type 5 inhibitors. Since their mechanism of action differs between the three classes, they can be used together to augment their effects. Prostate size does impact the medication choices during medication management of BPH. As the prostate increases in size, surgical intervention often becomes necessary. Here is a list of the different surgical procedures that can be done. The transurethral microwave thermotherapy is an outpatient device that heats up and causes coagulation necrosis of prostate tissue. Alpha blockers have been the mainstay for treating BPH since 1976 when phenoxybenzamine was shown to be effective in its treatment. Here is a chart of the alpha blockers that we will be reviewing today, along with their brand names. The non-selective receptor blockers are on the left and the alpha 1 are on the right. As for approved FDA indications, you can see all of them are approved for BPH except for prazosin. The mechanism of action of how alpha blockers work for BPH is by competitively inhibiting postsynaptic alpha-1 adrenergic receptors in prostatic stromal and bladder neck tissues. This reduces the sympathetic tone, inducing urethral structure caused from BPH symptoms. These agents have been shown to significantly improve scores, both irritative and obstructive symptoms, quality of life, and urinary flow rates, but they do not reduce the risk of acute urinary retention or the need for surgery later on. Here is the dosing of these agents in the use of BPH. However, it should be noted that when these agents are used with phosphodiesterase 5 type inhibitors, that the phosphodiesterase 5 inhibitor should be started at a lower dose and titrated slowly to avoid orthostatic hypotension. Additionally, tamsulosin should be given with meals, as an empty stomach increases bioavailability by 30% and the peak concentration as much as 70%. Only silodosin needs to be adjusted for renal impairment, and doxazosin should be cautiously used in liver impairment. As for warnings, this class of medication has been known to cause angina, CNS depression, and floppy iris syndrome. Floppy iris syndrome has been observed in cataract surgery patients who were on or previously treated with alpha-1 blockers. Unfortunately, this is not avoided by discontinuation of medication prior to surgery. The risk of floppy iris syndrome appears to be lower with older alpha blockers. They may also cause orthostatic hypotension, especially several hours after dose administration or addition of medications such as phosphodiesterase 5 inhibitors or nitrates. Patients should be warned of this, as oftentimes their LUTS causes them to make frequent trips to the bathroom at night. Alfuzacin has been shown to prolong QT intervals and should be avoided with other medications that also prolong QT intervals or in patients with pre-existing conditions. Here is a list of all the look-alike, sound-alike names for the alpha blockers. As for medication safety, several of these medications meet the Beers criteria for potentially being inappropriate for the use of geriatric patients. This includes doxazosin, prazosin, and terazosin. These medications have few adverse effects compared to other drug classes we have evaluated in the past. The most common adverse effects include dizziness, fatigue, constipation, and impotence. The alpha-1 blockers are metabolized through the cytochrome 3A4 system, and any inducer or inhibitor of this system interacts with all of the agents in this class. For example, duloxetine will increase the effects of alpha-1 blockers as well as the phosphodiesterase 5 inhibitors. And I've already mentioned how alfuzacin increases prolongation of the QT interval. These medications vary in response with food, primarily with bioavailability. Alfuzacin, silodosin, and tamsulosin should be given with a meal, and tamsulosin specifically should be given 30 minutes after eating, as an empty stomach increases peak concentrations 40 to 70%. Prazosin, on the other hand, should be given on an empty stomach for more consistent absorption. We have already touched on the precaution on concurrent diseases. Monitoring parameters include blood pressure, symptoms of LUTS, and urine outflow. Finally, these medications do not have any unusual administration, storage, or stability issues. We are now going to switch to the 5-alpha reductase inhibitors. There are two medications in this class. They are dutasteride, which is Avodart, and finasteride, which is Proscar and Propecia. Dutasteride comes in a capsule, whereas finasteride is available in tablets. The dosing for dutasteride is 0.5 milligrams a day. Finasteride is 5 milligrams every day. Maximum clinical benefits usually occurs anywhere from 3 to 6 months. Both agents are approved for the treatment of BPH as monotherapy or in conjunction with an alpha blocker. Dutasteride and tamsulosin are available in a capsule called Jalin. The strength of that is 0.5 by 0.4 milligrams. The way 5-alpha reductase inhibitors, or 5-REs, work is by blocking the enzyme responsible for the conversion of testosterone to dihydrotestosterone. There are two types of alpha reductase enzymes. Type 1 is in the periphery and type 2 is in the lower genitourinary tract. Dutasteride blocks type 1 and type 2, whereas finasteride blocks type 2. By blocking these enzyme types, the prostate decreases 20 to 25% in volume and the PSA blood levels by 50%. 5-REs have been shown to dramatically improve LUTS symptoms, improve urinary flow rates, and reduce the risk of acute urinary retention. These figures occur after about a year of therapy. Because they reduce the prostate, they also reduce the need for BPH-related surgery. In head-to-head comparison, dutasteride and finasteride perform similarly well in reducing prostate volume, improving symptoms, and improving urinary flow rates at 12 months. As I alluded before, these agents' mechanism of action augment the effects of alpha. These agents are metabolized through the cytochrome P3A4 system. Some of the metabolites have activity but have less than 20% activity for finasteride and even less for dutasteride. They are both highly protein-bound to serum proteins and semen. Lexicomp states that women of childbearing age should avoid contact with crushed or broken tablets or semen, as they can be absorbed through the skin, but it did not mention the specifics. So I imagine the recommendation for an elderly man married to a younger woman that the man should discontinue the 5-RE before attempting to have children, as abnormalities of the fetus genitalia have been reported in animal reproduction studies. These agents should be used in caution with severe hepatic disease. Both dutasteride and finasteride are listed as a hazardous agent in the National Institute for Occupational Safety and Health because of their reproductivity toxicity. This class of medications do have some notable warnings that are important to know about. For patients with severely decreased urinary flow, careful monitoring is recommended because of the possibility for obstructive uropathy, and thus these patients may not be good candidates unless an alpha blocker is added to improve urinary flow. Additionally, although 5-REs have been shown to reduce overall prostate cancer incidences, they have also been shown to increase high-grade prostatic cancer. They are also not approved for the prevention of cancer. Finasteride has been associated with incidences in breast cancer, and patients should be advised to report any changes that they have. A final important warning is that blood donating should be avoided during and up to 6 months following treatment to avoid administration to a pregnant female blood recipient. This class of medication also seems to be tolerated well. Adverse effects include decreased libido and usually occurs during the first 6 months of therapy. Ejaculatory disorders and gynecomastia with or without breast tenderness can also occur. Very rare but significant adverse effects include angioedema, cardiac failure, increased thyroid stimulating hormone levels, and testicular swelling. Even though both of these are metabolized through the cytochrome P3A4 system, neither have clinical significant drug interactions or food interactions. Specific monitoring parameters for 5-REs include symptoms of LUTS, urine outflow, PSA. However, finasteride does not affect free PSA levels. Now we will be covering the phosphodiesterase 5 inhibitors. The PD5 inhibitors are approved for erectile dysfunctions. Certain ones like Revatio and Adcirca are approved for pulmonary arterial hypertension. Evanafil only has approved indication for ED, so we will not be covering this in our review of this class. As you can see with sildenafil, this class has developed numerous off-label uses that I will place on the slide, but will not go over for the sake of time. Sildenafil has been studied off-label for BPH. Cialis does carry the FDA indication for BPH and ED in BPH. Finally, vardenafil only has been approved for the indication of ED, but has been studied off-label for BPH. PDE5 inhibitors increase nitrous oxide signaling in the genitourinary tract tissues, which causes calcium-dependent relaxation of endothelial smooth muscles and increased blood flow. By the same mechanism of action, phosphodiesterase 5 inhibitors have been found to improve BPH based on clinical studies. These medications are in tablet form. However, Revatio comes in oral and injectable solution. Staxin is a dispersible dose form of vardenafil. The dosing for sildenafil with an alpha blocker is 25 milligrams. Tadalafil use is not recommended with an alpha blocker, and the dose should be reduced when used with a strong cytochrome 3A4 inhibitor. Vardenafil is recommended for the use of alpha blockers at the dose of 5 milligrams a day. The dispersible tablet should only be used if a patient has been stable on the response of a regular tablet. The onset of action of all of these agents is approximately 60 minutes, and they are all metabolized through the cytochrome 3A4 system. Sildenafil also goes through the cytochrome 2C9 and vardenafil through the cytochrome 2C and the 3A5. Sildenafil does require a lower starting dose if creatinine clearance is less than 30 mL per minute and in mild to moderate hepatic impairment. No dose adjustment is necessary for vardenafil in renal or hepatic impairment. I will let you read over the possible look-alike and sound-alike medications for this group. These medications may cause dose-related impairment of color discrimination, decrease or sudden hearing loss. Other reports concerned include hypotension, priapism, pulmonary edema when treating pulmonary arterial hypertension, and vision loss from non-arteritic anterior ischemic ophthalmic neuropathy. These medications should also be used in caution in patients with cardiovascular disease, peptic ulcer, and pulmonary arterial hypertension. The major adverse effects occurring greater than 10% are related to the mechanism of action. They are flushing, headache, dyspepsia, and visual disturbances. The visual disturbance is related to the inhibition of phosphodiesterase type 6 enzymes in the eye. Less frequent adverse effects are dizziness, erythema, and diarrhea. These medications have quite a few drug interactions, but the important ones are those that can potentiate the blood pressure lowering effect in cardiovascular system. So concomitant use of nitrates, potent inducers and inhibitors of the cytochrome 3A4 system, and grape juice should be avoided. For vardenafil, use of potent QT prolonging agents should be avoided. Phosphodiesterase inhibitors should also be monitored for LUTs, blood pressure, and heart rate. At this point, I'd like to go into the systemic reviews of BPH. The National Institute for Health Care Excellence performed a review in 2010 on the management of LUTs. Here is a summary of this review as it pertains to the classes of medication we are reviewing today. Number 1, offer an alpha blocker, specifically alfuzosin, doxazosin, tamsulosin, or terazosin to men with moderate to severe LUTs. Number 2, offer a 5-alpha reductase inhibitor to men with LUTs who have prostates estimated to be larger than 30 grams or a PSA level greater than 1.4 nanograms per milliliter and who are considered to be at high risk of progression. Number 3, consider offering a combination of alpha blocker and a 5-alpha reductase inhibitor to men with bothersome moderate to severe LUTs for those prostates in the above mentioned ranges. Number 4 is an update for 2015. Do not offer a phosphodiesterase 5 inhibitor solely for the purposes of treating lower urinary tract symptoms in men except as part of randomized controlled trial. They concluded that there is a lack of evidence for men with LUTs without ED, since the current evidence includes those primarily with ED. So routine use at this point is not recommended until more studies evaluate its use in non-ED patients over the age of 45. Finally, anticholinergics, afternoon loop diuretics, and oral desmopressin are mentioned for addressing specific symptoms of LUTs, but we won't go into those more specifically. In 2011, the American Urological Association updated their guidelines on BPH. Their review consisted of Medline searches of English publications from January 1999 through February of 2008. Alpha blockers are considered appropriate and effective treatment alternatives for patients with bothersome, moderate to severe LUTs secondary to BPH, with AUASI scores of greater than 8. They did not include prazosin and non-selective alpha blocker phenoxybenzamine, as the data did not support recommendations for these agents for LUTs. Although there are slight differences in the adverse event profiles for the 4 agents, their recommendation is that they have equal clinical effectiveness. The older, less costly generic alpha blockers remain reasonable choices. The panel felt that the combination of alpha blocker and 5-alpha reductase inhibitors for patients with LUTs is an appropriate and effective treatment specifically associated with demonstrable prostate enlargement. 5-REs may be used to prevent progression of LUTs secondary to BPH and to reduce the risk of urinary retention and future prostate-related surgery, but is not recommended in the treatment of LUTs secondary to BPH without prostatic enlargement. They did not recommend 5-REs should be used without prostatic enlargement. There are 3 randomized trials evaluating the use of tolterodine as monotherapy or in combination with an alpha blocker in men with LUTs or BPH. But these trials do not significantly demonstrate the efficacy or effectiveness of tolterodine. However, the panel concluded that the use of anticholinergics could benefit some patients. In 2016, the Agency for Healthcare Research and Quality conducted a comparative effectiveness review through the Minnesota Evidence-Based Practice Center under contract. The purpose of the review is to evaluate medications used for LUTs caused by BPH that have been newly used in the last 10 years. This included 1 new alpha blocker, silodosin, all anticholinergics, beta-3 agonists, and phosphodiesterase 5 inhibitors. The key questions of the team sought to answer: first, what are the efficacy and comparative effectiveness of newer medications alone or in combination for LUTs attributed to BPH? What are the harms and comparative harms to newer medications for LUTs attributed to BPH? And then finally, do the comparative benefits and harms of newer agents for LUTs differ according to demographic or clinical characteristics? The following sources were used for a literature search. The reviewers included studies found up until July 2015. For statistical analysis, they used the following methods: risk ratios, weighted mean differences, and standardized mean differences for estimating outcomes with corresponding 95% confidence intervals. Tau squared test was used to measure study variance and magnitude of heterogeneity with the I-squared test. A few other statistical methods were mentioned in the methods. Out of their literature search, they identified a possible of 1,139 articles. After review, 57 were found to meet their criteria of randomized controlled trials. 11 were on silodosin, 20 involved an anticholinergic, 2 beta-3 agonists, and 24 studied phosphodiesterase 5 inhibitors. There were 4 studies evaluating silodosin versus placebo in BPH. Each study was 12 weeks long, and the average age of the patient in the studies was 63 years. These studies occurred in US, Europe, and Japan. 3 of the studies were sponsored by manufacturer and were rated to have low risk of bias. These studies supported previous evidence of other alpha blocker studies. That is, silodosin improved LUTs more than placebo, and the mean change in IPSS scores also was larger with silodosin than placebo. Silodosin 8 milligrams daily had a mean IPSS score of 6.9 points versus 4 points for the placebo. Finally, IPSS quality of life score also favored silodosin. The reviewers analyzed studies that evaluated silodosin versus tamsulosin. 8 randomized controlled trials were identified involving 1,705 patients. The doses for silodosin was 8 milligrams daily, and the dose for tamsulosin varied from 0.2 milligrams to 0.4 milligrams daily. The lower dose of 0.2 milligrams is commonly used in Japan. The studies varied from 4 to 12 weeks, with the average age of the patient being 67 years age. The mean IPSS score was 18, and the risk of bias varied from low to one study being high. The results were determined by the responder analysis and required a reduction in 25% to be considered relevant. The results indicated that both agents were similarly effective. Mean reductions in IPSS scores were 7.8 points for silodosin and 7.2 points for tamsulosin. Heterogeneity score with I-squared test analysis was 75%, and therefore the reviewers rated this analysis as moderate strength of evidence. The key points are displayed above. Silodosin improved short-term LUTs more than placebo. The effect size was small, but the level of evidence was moderate to high. Adverse effects, most commonly abnormal ejaculation, were higher with silodosin than with placebo. Number 2, silodosin and tamsulosin were similarly effective in improving short-term LUTs, though withdrawal rates were higher with silodosin. There have been some studies with the use of anticholinergics both as monotherapy and in combination with alpha blockers for the treatment in BPH. In general, these studies lack homogeneity to come up with solid strength of evidence, but I believe for our discussion today it is worth being aware of. And why? Most of these studies do not use IPSS scores and use tools such as bladder diaries. Those studies evaluating monotherapy had incidences where the anticholinergic agents had urinary retention among the participants. Other problems with these studies included no mention of sponsorship and also higher risk of bias. Here is the data pooling for the anticholinergic sulfenacin plus alpha blocker versus placebo. In these studies, they used the IPSS score and were able to determine the strength of evidence was high. The mean change in the IPSS score was minus 7.3 for sulfenacin in combination with the alpha blocker compared to placebo, which was minus 5.7. A slight improvement was also seen in the IPSS quality of life survey. When they reviewed sulfenacin alpha blocker combination versus the alpha blocker monotherapy and pooled the data together, they were able to determine that the treatments were similar in reducing the IPSS score and the quality of life, as you can see here noted in the red data. The reviewers determined the following about anticholinergic in the treatment of BPH. First, tolterodine alpha blocker combination and alpha blocker monotherapy were slightly effective for short-term LUTs. Second, sulfenacin and alpha blocker combination therapy improved short-term LUTs more than placebo over the short term. Next, sulfenacin alpha blocker combination and alpha blocker monotherapy were similarly effective for short-term LUTs. And then finally, they also concluded that there was insufficient evidence to determine whether adverse effects were different between the two treatment groups. Something to be aware of, but I won't go into much detail, is that the beta-3 blockers are being investigated for the use in LUTs. The beta-3 adrenoceptor subtype receptor in the bladder has been shown that when stimulated may increase bladder capacity without interference with micturition pressure, PVR, or voiding contraction. The medication mirabegron is in phase 3 clinical trials. There are 2 trials that have been completed. Currently, there is insufficient evidence of efficacy or adverse effects for mirabegron versus placebo or its use in combination with an alpha blocker compared to alpha blocker monotherapy. Evidence was also insufficient to assess efficacy or adverse effects of mirabegron compared with placebo. Evidence was also insufficient to assess comparative effectiveness or adverse effects of mirabegron alpha blocker combination therapy compared to alpha blocker monotherapy. Finally, there are no studies that assess long-term treatment harms. However, these studies have demonstrated decrease in micturition frequency compared to placebo. In addition, the 50 mg mirabegron group showed a statistically significant decrease in the urgency of episodes. In a few minutes, we will be reviewing the phosphodiesterase 5 inhibitors in more depth, but here are the key points that they came up with for this class. Tadalafil improved short-term LUTs more than placebo. Adverse effects were higher with tadalafil. Number 2, tadalafil and tamsulosin were similarly effective in treating short-term LUTs. Rates of adverse effects were similar, and withdrawal rates due to adverse effects were higher with tadalafil. Overall, from this review, we can conclude that number 1, that compared to placebo, the newer drugs or drug combination, cytolacin, solifenacin combination with alpha blocker, and tadalafil demonstrated improved clinical efficacy in LUTs caused from BPH. However, they do not offer any clinical advantage over the traditional alpha blocker treatment. Silodosin was more effective for LUTs than placebo, yet it was not more effective than the older alpha blockers. It was also associated with increased risk of adverse incidences. And then finally, the 3 anticholinergic agents tolterodine, solifenacin, and fesoterodine, when combined with alpha blocker, offer some benefit but no additional benefits for LUTs than just the traditional alpha blocker monotherapy. For the next few minutes, I would like to focus on the phosphodiesterase 5 inhibitors. A meta-analysis published in 2011 in Urology reviewing the safety and efficacy of phosphodiesterase 5 inhibitors for the treatment of LUTs and BPH. The reviews examined literature in the following databases from 1950 to 2010. Only randomized controlled trials were included and primary outcomes were in IPSS score and maximal urinary flow rate, or as Qmax. Secondary outcomes in these reviews evaluated changes in the IPSS irritative and obstructive subscores, IPSS quality of life index, which is designated IPSS-QOL, the erectile function domain score of the International Index of Erectile Function, and post-void residual urine volume, and other adverse events. Finally, the quality of these studies were evaluated on the JDAD scale of 0 to 5. The reviewers found 5 studies that met the inclusion of their criteria. Sample size was 2,054, and they used combination of subgroup analysis or pooled analysis for heterogeneity. The studies included tadalafil, sildenafil, and vardenafil. In short-term trials of 12 weeks, improvements were seen in the IPSS scores of the phosphodiesterase inhibitors versus placebo. Statistical significance was observed in the IPSS irritative and obstructive subscore. The review also demonstrated improvement in ED function. There was no statistical significant difference in Qmax, post-void volume, or significant side effects. However, phosphodiesterase 5 inhibitors were associated with more adverse incidences. The reviewers concluded that in addition to first-line treatment for ED, phosphodiesterase 5 inhibitors are also effective and safe for LUTs secondary to benign prostatic hyperplasia. For patients with comorbid BPH and ED, phosphodiesterase inhibitors could be considered as first-line treatment in the future. However, large-scale, well-designed clinical studies are needed to ascertain the safety, efficacy, and cost-effectiveness. There was another 2012 systematic review and meta-analysis on the use of phosphodiesterase 5 inhibitors alone or in combination with alpha blockers for LUTs due to BPH. This review was published in the European Urology and was similar in design, and the results supported those seen in the Liu et al. That we just reviewed. Yet this review went a step further to evaluate alpha blockers versus phosphodiesterase inhibitors in combination with alpha blockers. So, for the sake of time, I will focus more on in the combination portion of the review. Their results showed that the phosphodiesterase inhibitors and the alpha-1 adrenergic blockers improved the International Index of Erectile Function score and also IPSS when compared to those used of alpha blockers alone. Qmax was also improved compared to the alpha blockers alone. Conclusion: the reviewers concluded that for the first 12 weeks of treatment, phosphodiesterase 5 inhibitors are effective and well tolerated either alone or in combination with alpha blockers for LUTS and BPH. Combination therapy showed a small improvement in flow rates, whereas phosphodiesterase inhibitors alone were shown not to. The best candidate for phosphodiesterase 5 inhibitors in relation to urinary function was concluded to be younger men with lower body mass index and severe urinary symptoms. Most common adverse drug effects include headache, dyspepsia, and back pain. The researchers concluded that further studies are needed to evaluate the long-term safety and efficacy outcomes and the overall cost-effectiveness of this treatment. In 2015, the European Association of Urology published guidelines on the management of non-neurogenic male lower urinary tract symptoms, including benign prostatic obstruction. Systematic literature review was carried out by the panel for articles in English language published in PubMed, Medline, Web of Science, and Cochrane databases between 1966 through December of 2013. They used the 2009 Oxford Center of Evidence levels to rate their recommendations. Additionally, they rated medication classes that we are not reviewing today, as their use in BPH does not meet the criteria for being considered for the formulary addition. First, alpha-1 blockers can be offered to men with moderate to severe LUTS. Their second recommendation was 5-alpha reductase inhibitors can be offered to men who have moderate to severe LUTS and an enlarged prostate of greater than 40 mils. Third, 5-alpha reductase inhibitors can prevent disease progression with regards to acute urinary retention and the need for surgery. Next, muscarinic receptor antagonists may be used in men with moderate to severe LUTS who mainly have bladder storage symptoms. And then the final one, muscarinic receptor antagonists should be cautioned in men with BOO. Additional recommendations from their review included phosphodiesterase inhibitors reduce moderate to severe LUTS in men with or without erectile dysfunction. Vasopressin analogs can be used for the treatment of nocturia due to nocturnal polyuria. Beta-3 agonists may be used in men with moderate to severe LUTS who have predominantly bladder storage symptoms. And also, combination treatments with an alpha-1 blocker together with a 5-alpha reductase inhibitor can be offered to men with troublesome moderate to severe LUTS, enlarged prostate, and reduced maximum urinary flow rate. Other recommendations include combination treatment with alpha blocker together with a muscarinic receptor antagonist may be used in patients with troublesome moderate to severe LUTS if relief of storage symptoms has been insufficient with monotherapy with either drug. And then finally, combination treatment should be prescribed with caution in men who may have BOO. Here is the algorithm of the 2015 European Association of Urology published. In these next two slides, I'd like to review studies that occurred before our last review in 2011, so I merely want to mention them as they were reviewed then. MTOPS and COMBAT were two large long-term studies that have demonstrated the superiority of alpha blockers and 5-ARI combination therapy over monotherapy in preventing symptom progression, risk of acute urinary retention, and BP-related surgery. In the COMBAT study, the mean prostate volume was greater than the MTOPS, 55 mils versus the 36.3 mils. This has led to the recommendation by the AUA and the EAU of using combination therapy of alpha blockers and 5-REs for patients with moderate severe symptoms and high risk of progression of enlarged prostates, that is, prostates over 40 mLs, high PSA levels, and advanced age. In general, these studies support going to combination therapy when symptoms become refractory with monotherapy, but they do not necessarily suggest when combination therapy should be initiated. In 2006, the TIME study was published evaluating the efficacy of tolterodine and tamsulosin. In the TIME study, tolterodine and tamsulosin combination was found effective at reducing urgency episodes, number of micturations, and nocturia, as well as IPSS. However, tolterodine monotherapy was not. In 2007, the Saturn study evaluated the combination of tamsulosin and sulfafenicin versus tamsulosin alone and placebo. Combination therapy did not cause a significant improvement in total IPSS, but it did show considerable improvement in micturation frequency and voided volume compared to tamsulosin alone. In 2011, the Neptune trial resulted in combination of sulfenicin and tamsulosin OCAS, significantly improving storage and voiding symptoms, including quality of life parameters, overall over placebo. A study that was published in 2012 in European Urology studied phosphodiesterase 5 inhibitors in LUTS BPH. The purpose of the study was to compare the efficacy of tadalafil 5 mg once daily with placebo. A second reason was to compare tamsulosin 0.4 mg once daily with placebo as the standard. The study involved 44 sites in Australia, Austria, Belgium, France, Germany, Greece, Italy, Mexico, the Netherlands, and Poland. 172 patients were randomized to the placebo, 171 patients to tadalafil 5 mg, and 168 to tamsulosin. Patients that were eligible included men 45 years of age or older who had LUTS BPH of greater than 6 months at screening and an IPSS greater than 13. The maximum urinary flow rate was to be between 4 and 5 milliliters per second. The researchers used IPSS as a primary measure, BPH impact index, and International Index of Erectile Function Domain. Additionally, they used treatment satisfaction scale, and Qmax was monitored. 88.8% of the participants completed the trial. The mean age was 65 years of age, and 71% of the patients were from Europe. Initially, IPSS was greater than 20% in 30% of the subjects, and Qmax was less than 10 mils per second in 54% of the patients. The baseline change for both tadalafil and tamsulosin were statistically significant. Tadalafil minus 2.1 and tamsulosin minus 1.5. BPH impact index was also significant for the two agents compared to placebo. Tadalafil minus 0.8, tamsulosin minus 0.6. IPSS quality of life index, significant improvements compared with placebo at 12 weeks were reported with tadalafil, but not with tamsulosin. Compared to the placebo, both treatment groups experienced statistically significant improvements in Qmax with tadalafil and tamsulosin, as well as increase in Q average. Differences in the treatment group versus placebo were not statistically significant for volume voided or bladder capacity. There were no significant differences in adverse effects between the active treatment groups and placebo. The most common adverse effect for tadalafil was headache, dizziness, and dyspepsia, while those receiving tamsulosin most commonly experienced headache and dizziness. Tadalafil 5 mg once daily for 12 weeks resulted in clinically meaningful improvements in LUTS BPH similar to tamsulosin 0.4 mg daily. Also, tadalafil improved LUTS quality of life, global impressions of BPH symptoms impact, BPH symptoms satisfaction to endpoint, and improved erectile function for those men with ED. The limitation to this was that it was powered to assess each agent to the placebo, not each other. However, it was the first international study to demonstrate that phosphodiesterase 5 inhibitors were as effective as alpha blockers in the treatment of LUTS. The 2010 VA review of BPH focused on alpha blockers and uroselective alpha-1 blockers. Their recommendation was, given the comparable efficacy and current lower price, a non-uroselective alpha-1 blocker should initially be considered in the management of symptomatic LUTS due to BPH. Selective alpha-1A blockers should be reserved in cases when patients have contraindications or are not tolerating the non-selective agents. A 2013 Department of Defense review concluded that 5-alpha reductase inhibitors are therapeutically interchangeable without any unique benefit over the other, and that the product Jalin offers no additional benefits over individual agents. So conclusions that we can ponder upon. First, new alpha blocker sidolacin in systematic reviews demonstrated similar effectiveness in improving short-term LUTS as tamsulosin. Next, tolterodine and solafenacin alpha blocker combination and alpha blocker monotherapy have been shown to be similarly effective for short-term LUTS. However, oxybutynin and trospium have not. Dutasteride and finasteride are similarly effective in reducing prostate volume and improving Qmax and LUTS over a 12 months period. Finally, tadalafil improved short-term LUTS more than placebo and compared to tamsulosin was similarly effective in treating short-term LUTS over a 3 to 4 month period. In the last review of BPH in March of 2011, the committee voted on maintaining terazosin and doxazosin. Secondly, they added the selective alpha-1 adrenergic antagonist tamsulosin. And third, they added finasteride to the national core formulary. In 2013, oxybutynin and trospium were added to the formulary. Oxybutynin was first line in patients less than 65 years of age without any cognitive deficits. Since trospium has been shown to cause less cognitive impairment, it is recommended as first line in patients with or at risk for dementia. So this is what the VA and DoD have on formulary for these agents. For alpha blockers, they both have alfuzosin, tamsulosin, and terazosin. The VA also has doxazosin. Both have finasteride and sildenafil. Although I did not focus on anticholinergics in this review, I thought it would be worth noting what the agents have for these. For anticholinergics, they both have oxybutynin, but the DoD has tolterodine in their basic core formulary. After reviewing the medications for BPH and knowing that they both treat high volumes of males, I understand why they may have sildenafil and tolterodine on formulary. Although I believe phosphodiesterase inhibitors do play a growing role in the treatment of BPH, based on the growing studies, I do not think they meet all the criteria for adding a medication to the national core formulary. However, one could argue that its use in ED and pulmonary hypertension, and when one of these medications eventually go off patent and the price is right, we may see one of these things on our formulary. So at this time, I do not think it's necessary to have any additions or deletions to the formulary. Finally, I think it would be beneficial for a formulary brief to be developed highlighting what we discussed today. These are the references that I used for this presentation. Thank you again for listening to my presentation, and if you have any questions, please feel free to ask now.